Hello, my name is Maria Altieri, and I'm an assistant professor at East Carolina University Brody School of Medicine. I would like to thank SAGES, the program committee, and the moderator of this session, Dr. Holcomb and Dr. Lloyd, for the opportunity to present on when does postoperative gastroesophageal reflux disease present, current surveillance recommendations. I have no relevant disclosures for this talk. During my talk, I'll briefly discuss the incidence from the literature on reflux following bariatric surgery, some of the factors that may contribute, also touch on a few articles discussing reflux following the Roux-en-Y gastric bypass, band, and sleeve gastrectomy, and then highlight the most recent IFSO and ASMBS guidelines, which were published in 2020 and 2021, respectively. From the literature, it is reported that de novo reflux can occur in about 10 to 15% following the band, up to 35% for sleeve gastrectomy, questionable to 1.7% following the bypass, and 14.3% for intragastric balloon placement. Why do I say questionable for the bypass? A lot of the articles, and I'll go over some, are reporting good outcomes of reflux following the bypass, thus de novo reflux hasn't been reported in many, and currently there are no reports of Barrett's following the bypass. The 1.7 comes from an article that was published in Obesity Surgery in 2016 by Jamu and Sharma, who reported their case series. And in that, they reported 1.7 following the bypass. However, it is unclear whether this is de novo reflux. And in addition, there were no mention of preoperative endoscopy. So what are some of the reasons for development of reflux following bariatric surgery? I'm just presenting these for completeness, as one of the other talks will go over them in more detail. Most studies, and these are only the most common reasons, are reporting weight regain, hiatal hernia, or issues with the esophagus, such as weak lower esophageal sphincter pressures, esophageal dysfunction, or transient lower esophageal relaxations. Some of the reasons. So while bariatric surgery can have other etiologies and the indications can be different, just wanted to cover the standard indications for screening upper endoscopy in the general population. For the general population, the Clinical Guidelines Committee of the American College of Physicians currently recommends that screening EGD should not be routinely performed for heartburn symptoms in isolation for women of any age or men under the age of 50. They recommend that an upper endoscopy should be performed in patients with symptoms that include heartburn associated with alarm symptoms, and these are bleeding, dysphagia, vomiting, weight loss, or anemia. They're also recommending that a screening endoscopy be performed in persistent reflux symptoms despite maximum dose of PPI therapy, just twice daily for after 4 to 8 weeks. And also they're recommending that screening upper endoscopy be performed for men above age of 50 with chronic reflux symptoms of above 5 years and additional risk factors for esophageal adenocarcinoma. In addition to the recommendation above for the patients with reflux symptoms, a combined statement from the American College of Gastroenterology and the Canadian Association of Gastroenterology recommend that patients experiencing symptoms of dyspepsia should undergo an upper endoscopy when they are above age of 60 to exclude upper gastrointestinal neoplasia. So these standard indications for upper endoscopy should also apply to patients seeking bariatric surgery or following bariatric surgery. However, we can expand these indications as summarized by IFSO and ASMBS specifically for bariatric surgery as well. So what does the literature show? Most studies that examine the effects of the bypass on reflux following bariatric surgery actually show really good results following the bypass. Of course, these are patients presenting with symptoms of reflux and showing improvement of symptoms. This is an example of that. But it also published in Annals of Surgery in 2016 their study of 53 patients before at 6 months and about 3 years following surgery. Incidence of reflux decreased from 64% prior to surgery to 40% at 6 months and 23% at 3 years. Also, the Meester scores significantly decreased, as well as incidence of reflux esophagitis from 45 to 32 to 19% respectively, which was also statistically significant. Another study by Andrew et al. That was published in 2018 examined 19 patients with biopsy-proven short-segment Barrett's esophagitis prior to procedure. 7 patients had reflux. 14 of these 19 patients had at least 1 year follow-up, and 6 of these had histologic regressions of Barrett's to normal esophageal mucosa with no evidence of ongoing Barrett's. Majority of the patients, 93%, showed compliance with continued PPI therapy at least the first year after surgery. In regards to the band and outcomes of reflux, this article was published in 2010 and examined 20 studies with over 3,300 patients. The prevalence of reflux symptoms decreased postoperatively from 33% to 7.7%, and medication use from 27.5% to 9.5%. However, newly developed reflux symptoms were found in 15% of these patients. The percentage of esophagitis decreased postoperatively from 33.3% to 27%. Newly developed esophagitis was observed in close to 23% of the patients. Pathological reflux was found in close to 56% preoperatively, and postoperatively in about 30% of the patients. And the percentage of dysmotility increased from 3.5% to 12.6%. So the authors concluded that adjustable gastric banding has anti-reflux property resulting in resolution or improvement of reflux symptoms. Normalized pH monitoring results in a decrease of esophagitis on short term. However, worsening of newly developed reflux symptoms as esophagitis were found in a subset of patients during longer follow-up. So that was concerning. There was an extensive literature on the outcomes of sleeve gastrectomy and reflux. And these are best summarized by the latest ASMBS statement, which was published in 2021. In this statement, the endoscopic findings before and after laparoscopic sleeve gastrectomy were examined, and that encompassed 11 studies with close to 1,200 patients at baseline, about 1,000 patients with follow-up of either one, like up to above 10 years. 4 case series reported rates of reflux following the laparoscopic sleeve gastrectomy with 67.4% incidence. However, 2 of these studies reported that patients had reflux at baseline, and one study was 20, the other one was 41%. Thus, the 67.4% is not de novo reflux. Very alarming, though, it's the Barrett's esophagitis that following sleeve gastrectomy was 10.7%, and that was none in baseline. So based on the literature, IFSO and ASMBS published their statements. So IFSO published this in 2020 in Obesity Surgery, and their recommendation is that upper endoscopy should be undertaken routinely for all patients after bariatric surgery at 1 year, and then every 2 to 3 years for patients who have undergone either a laparoscopic sleeve gastrectomy or one anastomosis gastric bypass or mini bypass, to enable early detection of Barrett's or upper GI malignancy until more data is available to confirm the incidence of these cancers in practice. Also, they recommended that upper endoscopy should be performed following the band or the bypass on the basis of upper GI symptoms. The reason for the recommendation for the one anastomosis gastric bypass is that there's a theoretical concern of upper GI cancers on the basis of bile reflux. However, to date, there has been only one case report of esophageal adenocarcinoma 2 years after the surgery. So given this theoretical risk, this is the reason for why the statement was made. On the other hand, ASMBS published a statement in 2021, and in their statement, they are recommending that given the inferior GERD outcomes following sleeve gastrectomy, patients with reflux and Barrett's should be offered the Roux-en-Y gastric bypass if no contraindication is present. De novo Barrett's has been reported after sleeve gastrectomy, but none in the literature thus far at the time of the statement following the Roux-en-Y gastric bypass. So all cases reported to date were non-dysplastic and short segment Barrett's esophagus. Long-term clinical implications in the setting of bariatric surgery are not yet known. And their recommendation for screening upper endoscopy should be considered for all symptomatic patients after bariatric surgery and all patients at or after 3 years following sleeve gastrectomy, irrespective of symptoms. So in conclusion, there's a low incidence of reflux following the bypass, and then higher in the band and highest in laparoscopic sleeve gastrectomy. The ASMBS statement is recommending that screening should be done in all symptomatic patients after bariatric surgery or at or after 3 years for sleeve gastrectomy, irrespective of the symptoms. Whereas IFSO is recommending that for one anastomosis gastric bypass and laparoscopic sleeve gastrectomy, all patients are screened at 1 year and then every 2 to 3 years. Thank you, and let me know if you have any questions.